Hi everyone, my name is Carlyn Tan. I'm a faculty member treating myeloma at Memorial Sloan Kettering Cancer Center. We had an abstract that we presented at EHA titled Real World Less Frequent Dosing of Teclistamab in Patients with Relapsed Refractory Multiple Myeloma. One of the reasons we did this study was to evaluate less frequent dosing of teclistamab in a real-world setting. We looked at patients that were receiving that transition treatment from weekly dosing to every 2-week dosing or even monthly dosing to see if they were able to sustain their response. And in the future, we will be looking at whether their risk of infection was decreased because of this. We conducted this real-world study that included patients treated at Memorial Sloan Kettering between November 29, 2022 to March 1st, 2024, with the last data cutoff being April 17, 2024. For the overall patient population, we looked at 86 patients with relapsed refractory myeloma who received at least one dose of teclistamab. The median age was 71. There were 37% of the patients that had had prior BCMA-directed therapy before receiving teclistamab. In the 77 response evaluable patients, the overall response rate was 61%, with 43% of patients having achieved a very good partial response or better. The overall response rate for patients who had had prior BCMA-directed therapy was 43%. The subgroup of patients who were able to transition to less frequent dosing was 32 patients out of the 86 patients in our cohort. 30 patients went from weekly to every 2-week dosing, and 2 patients went to monthly dosing. The transition to less frequent dosing occurred after a median of 3.3 months from the start of teclistamab. The reasons for switching included patients achieving at least a partial response and or patients who had had some toxicity, including infection. 31% of the patients who switched to less frequent dosing had received prior BCMA-directed therapy, and 59% of the patients had high-risk cytogenetic abnormalities. After a median follow-up of 6.4 months since switching to less frequent dosing, the 6-month progression-free survival rate from the date of switch was 90%, with 28 out of the 32 patients still maintaining a response, some of which had deepening of their responses and have continued on teclistamab. 3 patients did subsequently develop progression of disease, and 1 patient unfortunately died from infection with active myeloma. So in our real-world analysis, patients that were treated with commercial teclistamab had multiple high-risk features, but despite these disease characteristics, teclistamab demonstrated comparable overall response rate to the pivotal MajesTEC-1 study that led to the FDA approval of teclistamab. In patients that who did respond or for reasons of safety management, switching to less frequent dosing was feasible with a relatively high 6-month progression-free survival rate from the date of switch. Our future research will update the efficacy and safety outcomes with longer follow-up, including assessing the long-term impact of teclistamab given at a less frequent dosing schedule.